Today we will discuss adolescent idiopathic scoliosis. Adolescent idiopathic scoliosis, a coronal curve of more than 10 degrees with a rotation, affects about 1 to 3% of the children. Curves more than 30 degrees are more common in female in the ratio of 10 raised to 1. Smaller curves are common equally in both males and females. Right thoracic curve is the most common pattern. Left thoracic curves are rare and indicate an MRI to rule out cyst or serings in the spine. Etiology: despite identification of numerous associated genetic foci and a pattern of autosomal dominant inheritance with a variable penetrance, clear etiology for this condition remains inconclusive. Pathogenesis appears to involve anterior overgrowth of the vertebral bodies, and a progression is related to the amount of skeletal growth remaining and curve magnitude at presentation. Coming to the presentation, usually parents bring the children with a back deformity or a limb length inequality, midline skin defects such as hairy patches, dimples that indicates a spinal dysmorphism, shoulder height differences, truncal shift, rib rotational deformity or rib prominence, waist asymmetry and pelvic tilt. After examination of the patient, the recommended investigations is an X-ray of the whole spine, standing AP and lateral. In that you have to measure a corpse angle, which is more than 10 degrees is defined as a scoliosis, and commonly intra-observed variations of 3 to 5 degrees seen. In this scoliosis, we have to understand certain terms. The first one is spinal balance. A coronal balance is determined by alignment of C7 plumb line to central sacral vertical line, that is spinal balance. Sagittal balance is based on C7 plumb from the center of C7 to the posterior superior corner of S1. In X-rays, you have to identify the stable zone. It is between the lines drawn vertically from the lumbosacral facet joints. Stable vertebra, most proximal vertebra, that is most closely bisected by central sacral vertical line. Neutral vertebra, a rotationally neutral vertebra, that is called neutral vertebra. Spinous process equal distance to pedicles on PA X-ray. End vertebra. End vertebra is defined as the vertebra that is most tilted from the horizontal apical vertebra. Apical vertebra. The apical vertebra, the disc or the vertebra deviated farthest from the center of the vertebral column. Clavicle angle, a best predictor of post-operative shoulder balance. Sometimes we have done an MRI scan of the spine in scoliosis. The purpose is to rule out intraspinal anomalies, and it should extend from posterior fossa to conus. The indications are atypical curve pattern, left thoracic curve, short angular curve, apical kyphosis or a rapid progression, excessive kyphosis, structural abnormalities, neurological symptoms are pain, foot deformities, asymmetric abdominal reflexes. Syrinx is associated with the abnormal abdominal reflexes and a curve without significant rotation. Coming to the treatment, observation alone is indicated if the corpse angle is less than 25 degrees. You have to obtain a serial radiographs to monitor the further progression, and bracing is indicated if the corpse angle is more than 25 degrees and less than 45 degrees. Only effective for flexible deformity in a skeletally immature patient. It has no role in congenital scoliosis. Goal is to stop progression, not to correct the deformity. With the bracing, you can prevent the progression to some extent, but you can't correct the deformity. Risk of growth related progression. There are two types of systems are there. One is a riser staging, and other one is a simplified skeletal maturity scoring system. Riser staging differentiates later stages of maturation, but use of a simplified staging system has rapidly and reliably predicted the risk of growth-related progression, which is greatest at stage 4 or below. This system is reliable and correlates more strongly with the behavior of the idiopathic scoliosis. The effect of bracing in adolescents with the idiopathic scoliosis. The study was published in October 2013. A prospective randomized study confirmed that bracing lowers the rate of curve progression and the need for the surgery compared to observation only. The trial was stopped early owing to the efficacy of the bracing. In an analysis that included both the randomized and preference cohorts, the rate of treatment success was 72% after bracing as compared with the 48% after observation. There is also one study in January 2016 in JBGS on bracing. Success with the bracing is also related to number of hours worn, with more than 16 hours per day needed for an optimum outcome. Patients who wore their brace more hours per day had less curve progression. Patients in both the groups who had a curve progression to magnitude requiring surgery wore their brace less than their counterparts for whom bracing was successful. Compliance monitoring and counseling based on that monitoring should become part of the clinical orthotic management of patients with idiopathic scoliosis. Curve pattern matters in idiopathic scoliosis. Brace success is related to curve type in patients with idiopathic scoliosis. There was a study in 2017 in JBGS. Lumbar curves had a higher chance of success with a brace than thoracic curves. The rate of surgery or progression to more than 50 degrees was 34.1% in combined thoracic group and 15.4% in the combined lumbar group. Thoracic curves are at a greater risk for brace failure than lumbar curves, despite similar initial curve magnitudes and average amount of daily brace wear. If left untreated, curves greater than 50 degrees will likely progress over time. Progression increases rates of back pain but not mortality. 22% of patients complained of shortness of breath during everyday activities compared with 15%. Untreated adults with lumbar idiopathic scoliosis are productive and functional at high level at 50-year follow-up. Untreated LIS causes little physical impairment other than back pain and cosmetic concerns. Coming to the deformity correction. Instrumented deformity correction and spinal fusion is the intervention of choice for larger curves. The posterior only approach employing pedicle screws now being the most common technique. The Lenke classification is the most widely used system to describe and select reasons for fusion. All three regions of the radiographic coronal and sagittal planes, the proximal thoracic, main thoracic, and thoracolumbar or lumbar designated as either the major curves or minor curves, with the minor curves separated into structural and non-structural types. The recommendations are that the major and structural minor curves are included in the instrumentation and fusion, and the non-structural minor curves are excluded. Count vertebra correctly before the surgery. Variations in the number of thoracic or lumbar vertebrae were found in 10% of the patients with the adolescent idiopathic scoliosis, but had been identified in only 0.5% of the radiology reports. Assessment of possible variations in the number of vertebrae is important to help avoid surgery at wrong vertebral level. The relative efficacy of antifibrinolytics. The tranexamic acid and epsilon amino caproic acid reduced operative blood loss but not transfusion rate. The tranexamic acid is more effective at reducing post-operative drainage and total blood loss compared with the epsilon aminocaproic acid. Not surprisingly, increased surgeon experience lowers the operative time and blood loss and improves outcome scores. Safety during surgery. Reversible intraoperative neurophysiological monitoring alters in patients undergoing arthrodesis for adolescent idiopathic scoliosis. Safety during surgery is aided by intraoperative neuromonitoring of sensory and motor pathways. Changes in IONM occur in 5% of cases, with higher rates seen with larger curves. Notable IONM changes occurred in 5.3% of the patients who underwent arthrodesis for AIS. Those patients had a larger preoperative deformity, a longer operative duration, a greater number of levers fused, and a higher estimated blood loss, and a greater volume of autologous blood transfused. Return of IONM data guided the surgeon to safely complete the procedure in 34 of 36 patients published in JBJS 2016, with a correction similar to that of patients who did not experience an alert. Return of signals, often after corrective action, allows the surgery to be completed safely during the same session. Patients can usually be cared for after surgery without intensive care, and this lowers the duration of the hospital stay and the number of laboratory tests. Coming to the complications, if not treated, it will progress, and these are some of the surgical complications: neurological injury, pseudoarthrosis, infection, flat back syndrome, superior mesenteric artery syndrome, heart valve failure. These are some of the common complications, not common, or complications of the spinal surgery.